Hi, it's Manesh Patel here from Duke University at the Heart.org booth at the American Heart Association meetings in Orlando in 2011. I have the pleasure of talking to Dr. Nicholls from the Cleveland Clinic regarding a couple of studies. The first is the SATURN study. Can you tell me about the SATURN study and what findings you were looking into?
So we've used intravascular ultrasound to look at the effect of medical therapies on the growth of plaque in the coronary arteries for a number of years. And one of the consistent findings is that statins slow disease progression, and in some cases they can actually regress plaque. And it's not just because they lower LDL. Turns out it's also because they modestly raise HDL. But we've never directly compared the two most effective statins at their highest doses, which is what we wanted to do in the SATURN study. So we directly compared the effects of atorvastatin 80, rosuvastatin 40 milligrams for 24 months in over 1,000 patients studied with intravascular ultrasound. So this is a battle of the titans in terms of highest doses of the most effective statins. It's the biggest imaging study we ever performed, and we wanted to know whether there would be a difference in terms of plaque progression.
Wonderful. And tell me what you guys found.
So rosuvastatin resulted in a lower level of LDL, 62 versus 70 milligrams per deciliter. It resulted in a slightly higher HDL, 50.4 versus 48.6, maybe a little less than we would have anticipated. The primary endpoint is what we call percent atheroma volume, profound regression in both treatment groups, much more than we've ever seen. No statistically significant difference between the groups, p-value of 0.17. The secondary endpoint was another marker of plaque called total atheroma volume, again marked regression in both groups. This time slightly more in favour of rosuvastatin with a p-value of 0.01. We see about 2/3 of individual patients actually regress, and in those patients who regress, they regress a lot. We looked at safety and tolerability. It's very well tolerated. There was very low incidence of liver, kidney and muscle biochemical abnormalities, which was enormously reassuring, because I think part of the problem here is that patients and doctors don't like to use the high doses of these drugs. So the bottom line is high dose effective statin therapy, safe and well tolerated, very low levels of LDL, raises your HDL, and most importantly for patients with coronary disease, profound regression of plaque.
That's awesome. And tell me what you think you're going to do next with this. Are you going to follow the patients to see if this translates into event reduction?
Well, I think we're going to explore a number of things. I think we have a look at the event rate during the study, which was lower than we've previously seen, and that would be consistent with the fact that they were regressing. It would be interesting to see if we could follow them longer term. We'll have to kind of give some thought to that. We're looking at some of the biochemical predictors of regression. We've really changed the bar now. The new gold standard is a lot of regression. So now we need to understand what really drove that, but we also need to think about the fact that 1/3 of patients didn't regress.
Yeah.
So why didn't they regress, and does that actually give us targets for new therapies to try and reduce their cardiovascular risk?
Well, thanks again for joining us and presenting wonderful science here.
Thank you.